from Perdana University School of Occupational Therapy. So older adults face many challenges, and this can be viewed from different perspectives, and it is an honor for me to be chairing this session. We are proud to have three experienced speakers with us to further elaborate on this topic. Let me first introduce the first speaker, Associate Professor Dr. Mazlina Mazlan. Dr. Mazlina Mazlan is an Associate Professor in Faculty of Medicine, University Malaya, and currently the Head of Rehabilitation Medicine Department and the Chairperson for Brain Injury SIG of Malaysian Association of Rehabilitation Physicians. She leads the Acquired Brain Injury Rehabilitation Clinical Service in UMMC since 2009 and has expanded the service to include return to work, neuromodulation, and neurovisual optometry rehabilitation clinic for neurological disorders. She is an expert in medical and functional evaluation of people with disabilities, including neurocognitive impairments. She has supervised projects and written papers related to cognitive evaluation and interventions in different clinical conditions such as traumatic brain injury, stroke, and also cancer survivors. She is also appointed as an independent senior medical specialist in writing medical legal reports related to complications after neurological disorders. Without much ado, let's welcome Associate Professor Dr. Mazlina Mazlan with her topic entitled Cognitive Strategies in the Golden Years. Please welcome.
Okay, good afternoon everyone. Assalamualaikum warahmatullahi ta'ala wabarakatuh. In the next 15 minutes, I want to talk about, or just a brief summary on the cognitive strategies in the golden years. Okay, well, I'm trying to get another mic. Thank you. Yeah. So this is the first face-to-face meeting or conference that I've attended, and I'm trying to give a talk, so I'm actually very excited. Okay, as we know, the cognitive decline in elderly is actually something that is, it's written in the literature. We know that with age, there is also going to be a cognitive decline, but it doesn't mean that it is pathological. Okay, most of the time of this elderly with the cognitive aging, we call it normal cognitive aging, it doesn't really affect the person's function. And in normal cognitive aging, actually there are many or certain domains that are resilient to the cognitive decline. For example, language and verbal ability sometimes maintain, and it can also improve with time or with age. You know, I suppose some of you know that you sometimes you learn new language. You know, some people learn Arabic, learn different languages when they age, and that's why the language ability normally is a bit resilient and maintained with older age. But domains such as memory, processing speed, and also abstract reasoning are those that are not so resilient and normally start to decline earlier. Whereas attention, the domain that within the attention domain itself, the one that you can see a decline with age is actually the one that involve multiple tasks or complex activities, which is normally like divided attention or alternative attention. And mental flexibility is within the executive function, because the executive function you need reasoning, abstract, and mental flexibility, and you see that these domains normally decline at a later age, for example, after 70 years old. So, but, okay, I'm putting this slide because people say that men are from Mars, women are from Venus. I mean, even with age in elderly, there are also cognitive profiles differences between the male and the female. In the literature shows that the men, the elderly men, normally have more holistic or global cognitive profile. So they can use a more holistic way to solve tasks, everyday tasks, as compared to women, elderly women. We normally have more of a local cognitive profile and use a more domain-specific subsystems to solve tasks. And somehow, elderly men also are better in tasks that require visual and visual-spatial cognitive abilities. For example, they are better at reading maps. I don't know whether this is true or not true, but then somehow in the literature says that because the elderly men have a better visual spatial abilities, they can read these maps probably easier than probably I am when I'm much older. Okay, so that is what we know. There are differences between the cognitive profiling in men and women when they are in an older age. So how can we try to prevent this decline? So there is this term that we say just now, I've said there is a cognitive aging, but what we want is to be able to have a successful cognitive aging, which means that if you look at this diagram, there are factors that, risk factors and also protective factors across the lifespan. If you look at the risk factors, genetic makeup, and then the socio-economic factors. But if you look at the protective factors, I think that is what's most important, is that someone with a higher education, someone who's also participate in meaningful activities, if they participate in physical exercise or mental exercise, those who have a higher socio-economic status and have rich social networks, even at the older age, these are the people that, or the factors that is protective towards aging, cognitive aging. And this, again, I've mentioned earlier, the normal age-related cognitive change do not really impair a person's ability to perform most of the daily activities. So even with age, with the cognitive decline, you're still able to be independent. But there are two theories or hypotheses why this happened. One is because of cognitive reserve, and another one is the lifestyle cognition hypothesis. Okay, let's see what this cognitive reserve means. Cognitive reserve means that some of us have the greater ability to withstand pathologic changes to the brain. We have active reserve or passive reserve. Passive reserve just means that you have the genetic makeup in you that can withstand these challenges. The passive reserve means that there some of us has ability, the brain cells ability to have a higher rate of plasticity when something happens with a cognitive decline. You can, with learned and with certain strategies, the brain cells or you yourself can achieve that faster, improve the cognitive decline. And the second one, just now when I mentioned, is the lifestyle cognition hypothesis. It just means that a person needs to participate in a certain lifestyle, active lifestyle that involve the physical exercises and mental exercises, especially cognitively engaging activities. And this will somehow help a person to have a successful cognitive aging. Which means that if you don't use a certain your cognitive abilities, you may lose it somehow. So you have to be, according to that hypothesis, you need to maintain that activity or active lifestyle. All right, the cognitive interventions and strategies. There are in the literature certain strategies, interventions to minimize the functional decline with advancing age in healthy adults. So there are, basically, we can divide it into three, like one, training or cognitive strategies to look at specific cognitive function, which means that if you want to train somebody to improve their memory, so you train memory skills. But then again, there's also another strategy, try to generalize this skill to daily function. So you don't just treat or train somebody with just the memory skills, how to remember things, but you want to teach or introduce them to daily function that uses that memory skills to perform an activity. So this is what we say, that another training looking at generalization to daily function. Another term is a cognitive stimulation. This is basically a very non-specific cognitive exercise, which means that you just put a person to be involved in certain cognitive stimulation activities. But this activities or stimulation is actually not structured and it's not guided to a specific cognitive domain. Yeah, so you just involve in a more activities, play mahjong or something, or just with your peers. Okay, And how do you deliver these strategies? You can deliver using this pencil and paper tests or strategies, which is actually sometimes a bit boring. And but then again, that's how people use it. Something that you can write, at home. But there are also strategies that can use computers. We always think that probably the elderly will not be very fond of engaging in computerized programs, but there are studies overseas at least showing that it improves, and people are accepted. They can accept computer strategies to improve the cognitive decline. And the last is about ADL, trying to improve your activities of daily living. But we have to remember that all the strategies that we give, it has to follow the principle of neuroplasticity. Because what we want to do is that we want to do a certain program or strategies or interventions every day until it becomes until it becomes ingrained. So what we mean by neuroplasticity is that the brain cells and the cells or the parts of the brain that are supposed to conduct or for the certain cognitive function has already changed, and that needs the meaning that the strategies need to have enough intensity. You have to repeat many times. Intensity just means the difficulties of the strategies. It has to be salient, important to the person. You cannot ask them to remember. If you ask them, let's say, if you ask a person to remember certain things, and if a person likes to bake, for example, might as well ask them to remember things that is important, and then the person feels that it's good to remember, rather than giving items, any engineering tools or whatever other tools. So it has to be salient and perform in an enriched environment, and has to be task specific, which means that if you want to train somebody to remember, you have to make sure that the person do exercises to remember. So, and that's the meaning of task specific. And use it or lose it is also another principle in neuroplasticity. You need to do it all the time, and you cannot leave that certain function, or you may just lose it. Okay, examples of the cognitive strategies. These are the examples that I collect from the literature that has been done on elderly. For example, if you want to improve attention, you can actually try to solve maze. So the maze can you can start with something very simple, and then increase the intensity. Remember, intensity is also part of neuroplasticity, so you need to increase the difficulty level from time to time. And this is another one that I used to like to do this when I was younger, spot the differences. So it's quite nice. I mean, it's quite challenging, it's quite entertaining, but this is also to improve attention. For example, here you can see one missing egg here, and then, I don't know, here, yeah, some pieces here, and then this, if you look at this picture, I think the angle is different. So this is the thing that you can also do to improve attention, and this has been done in the literature. For episodic memory, okay, this is an exercise that I said it has to at least be salient or something that is within our culture, so it's easier to engage the elderly to perform all this exercise. You can look at this picture of the house. You can analyze the picture. When the picture is no longer present, maybe you can try to describe and see if you can describe and answer all the questions about the picture. So I'm going to give about 3 seconds. 1 Mississippi, 2 Mississippi, 3 Mississippi. Okay, can you describe the picture? All right, and then where do you think this house is located? What do you see at the top of the staircase? How many people can you see at the veranda? And what are they doing? This is just an example of questions that you can do, when you provide cognitive strategies or cognitive interventions to the elderly for episodic memory. Okay, next. This is for processing speed. Processing speed is one of the main, domain that is affected, start from an earlier age, and goes into the elderly age. So it's just an example of useful field of view. So this is one of the computerized system that was used in one of the clinical trials for elderly, which means that this cute car here will appear and disappear from the screen, and then you have to, as fast as possible, try to locate where the car is. So that's why it's a computerized system. So you just blink, and then you have to choose where the car is there on the screen. So this is an example of how you want to provide processing speed exercises. Okay, reasoning. So reasoning, this is using the pictures and also using alphabets. to see all these relations. So using these, and then you have to choose which one do you think will suit this grid. And also with all these letters, so what is the next letter? What do you think? So this is normally trying to test reasoning. And if any of you have tried to sit for Mensa test before, so this is also one of the example of how the Mensa test is conducted. They're using all this reasoning and abstract thinking abilities. So this is also one that is used to try to improve cognitive decline in elderly. All right, Crazy Rich Asians. I don't know how many of you have watched this movie, but just now I said that if you want to try to introduce strategies to your patients, or to not patients, sorry, to the elderly, you should use something that is familiar to them, and this is mahjong. Well, you don't have to be very intense like this, but then you can play mahjong, and this can improve attention, reasoning, and probably processing speed as well, right? So it's just an example of activities that you can do to try to target certain cognitive domain. Okay, I'm just trying to test your ability, the audience today. I know this is not really a good picture, especially for elderly, because this looks very high impact dancing. Okay, but try to remember the sequence of the dance, and then I can test and ask you what. Okay, I'll give you about 2 seconds. Oh, sorry, this is actually quite fast, but by right we should give certain time. If you want to increase the intensity of the test, you can first give probably 5 minutes, and then give another picture, another sequence, give like probably 2 minutes. If you want to increase the level of complexity, while you give this picture for the person to remember, you can actually put music or something that distract them. So that is, again, that is increasing the level of the complexity and difficulty. So, all right, who knows the answer? Which one comes first? Yes. Number 3. Okay, very good. Which one is the last? Because sometimes people forget to remember. Yes. Number 2, last. Oh, very good. All right. I guess, but then again, if I ask you to put probably one after another, we probably will not remember. So, but this is how you can test. But normally, I put this picture is for somebody to teach them to say that you may use internal strategies or external strategies. Because for memory, if you want to test memory, there are certain ways you remember. I can ask you how you remember. How do you know number 3 and number 2 is the last? Because sometimes it's just you try to remember, just the image in your head. But I've tested this on somebody else before in a different audience, and one of them actually took a photo. So that is, and then try to just look at the photo again, from the camera, a phone camera. So that is external strategy. But most of the time in a normal elderly, when they age, they don't really have this cognitive impairment that you need to use external strategies. What you want is for them to build their internal cognitive strategies. Yeah. Okay, that's just an example. Okay, this is one of the last few slides just to show that cognitive interventions is effective in older adults. This is a review in 2020 looking at all the systematic reviews and meta-analysis that was conducted from 2010, but the studies go way back before, until 1983. The population in this review, the cognitive interventions, they have the authors actually look into 3 populations. One is in the healthy older adults, and the second group is in the older adults with mild cognitive impairment, and the third group is in elderly with dementia. But for the purpose of the lecture today, or the talk today, I will only mention about the healthy older adults because of time limitation. So there are about 4 reviews and meta-analyses with 79 studies. So the treatment group, you can see, is actually 9,000 over, with control group, mean age about 70 to 74. But in this group of population, they have 13 years of experience of education, with a group intervention and individual interventions like almost 50-50. And they can see significant improvement in the general cognitive functioning, and also in the specific domain such as memory, executive function, visual-spatial. They can generalize to the other tasks. Psychological well-being is catered and covered and improved in the review. I'm taking one of the study because this is one of the large clinical trial, looking at advanced cognitive training in the independent and vital elderly. And this one is one of the largest study in cognitive training in the elderly group. They looked at the long-term effect up to 10 years after training. It's a randomized controlled trial, community dwelling population, which is normal at baseline. The cognitive function is normal. And aged about 65 to 94 years old, they have about almost 3,000 people in this study. What they focus is on memory, reasoning, and processing speed. Because prior research has shown that these three domains are the one that's affected the most and earlier in elderly. They gave about 1 hour session of therapy over 5 to 6 weeks. The total therapy session is 10 sessions. And 39% of the population receive this booster training. It's like our booster dose. They also have booster training. But this booster training is towards the end of the third year. The first year and also third year, they have 39% of them receive all this booster training again, which is also about 1 hour per session. And the outcome, this one is just to show how they do the memory training, reasoning training, and the speed of processing. But I've already mentioned earlier in the examples, those are the strategies that they use. The outcome is they look at cognitive function at 10 years. So it seems that with the booster training at the end of first year and the end of third year, it actually produced additional and durable improvement for reasoning performance and processing speed when they measure at 10 years compared to those patients who don't receive booster. The elderly that do not receive boosters. And they also found that memory training alone, the effects is no longer maintained for memory performance at 10 years. But if you look at 5 years, there is a significantly less decline in the self-reported ability to perform ADL, instrumental ADL, compared to the control who do not receive those intensive training. At 10 years, dementia incidence, I think this is quite interesting to see. Almost 33%, one-third, have risk reduction in the processing speed training group, risk reduction of dementia. And those completed more training sessions had lower risk as well. But there's no significant difference in dementia risk for the memory or reasoning training group compared to the control. So a lot more to do with the group that received processing speed training. So that is the outcome for that one of the large study in cognitive training in the elderly. And so in conclusion, I think what you can take home is that cognitive training do promotes cognitive and neural enhancements in old age, even in normal elderly and those without dementia or without any mild cognitive impairment. But you have to choose the right cognitive strategies, whether you want to provide specific domain, cognitive domain, or you want to provide more the one with generalization to daily task, or you want to just, on top of that, in addition, to give more of a cognitive stimulation. So you need to choose which one that you think you want to give on a certain population. And you can either use pen and paper, you can use computerized tests, you can use certain activities, like just now I showed you about the playing mahjong as part of the training for cognitive, to prevent cognitive decline. You can use it individual or group. Most of the time, if you look in the literature, a lot of the literature shows that the elderly prefers group strategies rather than individual strategies. This is especially true in the those with normal cognitive baseline, and also those with mild cognitive impairment. But the elderly with dementia, they actually prefer more of an individual training and not in group therapy. So yes, you can choose either individual or group treatment or activities. And remember that try to use the principle of neuroplasticity, which means you try to improve and increase the intensity, the level of difficulties, make sure that they always use it or they may lose it, and other principles like salient and rich environment and so on. All right, I think with this is my last slide. Thank you very much.
Okay, thank you, Prof. Mazlina. Any questions from the floor? No? Okay. So I'll just have one question from myself. Okay. Prof?
Oh, yeah, sorry.
Yeah. Okay. Some of the cognitive activity that we provide for the patients appear to be childlike or age inappropriate. Okay. So how do you think that we can convince our patients to participate in the activity?
This is This is for patients or those with normal, just normal elderly
patients or
or normal elderly population. I think at the end of the day, before you start any program or any strategies to them, you have to include them if they still have that capability to understand and to that's why we need to discuss with them what is the goal. They need to understand. They need to have some ownership of the program and of the strategies, because it cannot be one way. They have to know that why we are doing this is to improve certain, for them to remember, to improve certain cognitive skill. And then I would like to always discuss with them what do they like and what is their interest, so that you can try to modify the strategies or the program more towards what they do rather than, I understand most of the basic or the generic cognitive program out there is really like not really like you said, it's childlike or something that do not really relate to their age and wisdom. They're really wise. Actually, they have a lot of experience, so we can plan with them. We can always plan with them. Yeah. So I'm sure and I really respect even especially the one that provide the therapists, all the occupational therapists. They're actually quite very motivated. They are very, how to say, and banyak idea lah. You have a lot of ideas how to do it. I'm sure you can come up with something.
Okay. Thank you, Prof.
Welcome
for that very insightful talk. Okay, let's move on to our next speaker. So we have now Mr. Thilainathan Krishnan, who is an occupational therapist working at the Family Health Development Division, Ministry of Health. So Mr. Thilainathan has a vast of experience working in the government sector, hospitals such as Hospital Tengku Ampuan Rahimah Kelang, HKL, Sungai Buloh, Selayang, and the current position. He has been actively involved in coordinating OT services in the health clinics and also community by involving in policy making processes, and also he ensures quality of health delivery system incorporating occupational therapy. Okay. Mr. Thilai also have been an active member holding various positions in Malaysian Occupational Therapy Association and also Malaysian Healthy Aging Society. Okay. Without much ado, let's welcome Mr. Thilainathan Krishnan with his topic, The Forgotten Disabled Elderly, Long-Term Care, Rehabilitation Needs and Community Integration. Thank you.
Thank you, Pak Aifa, for the kind introduction, and also fellow speakers of this symposium, and also participants still staying in this room and also joining us virtually. Welcome to this symposium, and let me go straight into my topic. I'll try to be precise and try to cut short lah, so that we can finish one time as much as possible. Okay, let's move. So looking at my topic of the day, it's regarding the older person which faced by the challenges faced by them about long-term care, the rehabilitation part, and also getting them back into the community, which is the community integration, and all this to do with the forgotten disabled elders, those who have memory problems, cognitive problems, and so on. So when we discuss about challenges, the various challenges which is applicable to everyone, but the type of challenges might vary according to their background, their situation, where they live, and so on. So it's basically these are the factors lah: physical, emotional, psychological, financial is a big thing, and also the housing, whether they stay in their own house, renting sons, children's house, and so on, and also the relationship between the household and also their friends and the community. And then communication is another thing, how they keep on communicating to get help, and also to stay in touch with others, and also transportation for good healthcare, to keep up in the society, and so on. So when we talk about long-term care, it's about the person's need for help, social and assistance from caregiver. Yeah, maybe it's for a long time, a long period of time, or some short period of time, but it's depending on their condition or disability itself that limits their functional independence in caring for themselves. So for in terms of forgotten elderly, where they tend to forget the daily routines and so on, it's very important for us to help that individual to do as much as they can do, and as well they can do, and as long as they can do their daily routines. Yeah. So when we talk about community integration, it's our main aim will be to ensure the quality of life, and also the multi-dimensional approaches which regards to the person-centered, individualized or tailored to the person's needs. We can't take everybody for granted, yeah, and it really needs a careful planning. That's why they need to be assessed, and also get them back into the community. Okay, our main goals will be maintaining their function, whether they have memory problems or so. We must maintain as long as possible their function in daily activities, and also at the same time they might have some challenging behaviors all along, yeah, especially those who are in long-term care. Yeah, so we need to be persistently managing their challenging behaviors so that it doesn't develop further. And also we need to reduce the comorbid emotional disorders, and also provide a good care environment. Yeah, so management of the challenges, it will be like the physical issues, yeah, and also the cognition part, the behavior, and also mood problems, and not to forget the caregivers. Yeah, we need to have a caregiver intervention plan also, because if not, they will also tend to have burnout syndrome. Yeah, so the assessment of the person or older person should include all the physical health, the functional status, yeah, whether they are psychological, depression, anxiety, and so on, possible undetected pain or discomfort. Most of the elderly, they complain of pain. Yeah, so this should be addressed also, and also the psychosocial factors, and also the physical environment, meaning their house and also their environment. Yeah, so as Dr. Ma have mentioned, ADL is the most important aspect for us to assess and also intervene, so that they can maintain their level of activity. Yeah, so these are the ADLs that we always emphasize for them to do in daily routine, so that they keep on doing it until they can. Yeah, so other type of interventions which are suitable for the disabled elders, yeah, will be like music therapy, physical activity, mobility programs, multi-sensory stimulations, massage and touch therapy, aromatherapy, life review, storytelling, and so on. Yeah, so this caregivers intervention, which I mentioned earlier, must also evaluate their caregivers' needs, whether they have any emotional issues, or whether they know how to take care when whatever problem arises. Yeah, and also the multi-component intervention of psychoeducation, supportive therapy, respect, care for them if they want to go and do whatever they like during the weekends, and so on, and training. Yeah, training for good management. Okay, so the interventions for disabled elders, the carer must be able to delineate the goal of therapy. In a team, we must know what is the goal of the therapy for this elderly person, and we need to identify the symptoms and behavior that we can discuss how to manage this problem, because everybody is unique and they might have different issues at all. And try to understand the approach to achieve the goals and give feedback on the progress, because they are there most of the time. So we need to always discuss with the caregiver, and also apply the techniques in everyday practice. yeah, so that they can integrate it back into integration. This will be our main aim, where we see a lot of elderly, older persons, especially with the cognitive functioning. They are retained at home without attending any social events, at least like going to do their religious or prayers, daily prayers once a week to the mosque or temples, yeah. So they must be able to continue with their work functioning, which is their roles as a grandfather, yeah, grandmother, and so on, and also involve them for the contribution in the community, and make use of them in the spiritual activities, and make them feel proud of themselves, and continue with the leisure activities, yeah. Work, leisure, and daily activities are most important, yeah. So let them continue whatever roles and responsibilities with some observations, and there are many more, yeah, challenges which we may want to overcome. So let's work together to identify individual challenges, work together as team with caregiver, and so on. Thank you so much for listening. I think I'll pass it back to Chairman.
Thank you, Mr. Tilai. Okay, I'm afraid that we don't have much time for questions, but Mr. Tilai is around, so you can ask him later. Okay, now we have Mr. Matthew Teo Yong Chang, who is a colleague of mine at Perdana University. He's an occupational therapist and also a lecturer in the School of Occupational Therapy. He graduated and obtained his degree in OT with honors at University Kebangsaan Malaysia. He also went to obtain his master's in neuroscience at University Science Malaysia. He also has some experience working at Tan Tock Seng Hospital in Singapore and Loh Guan Lai Hospital in Penang. Okay, without much. All
right, thank you.
Let's welcome Mr. Matthew Teo Yong Chang for his topic on issues and challenges of stroke patients in old age.
Good afternoon, ladies and gentlemen. I don't have much time, so probably I'm going to finish up with 5 minutes.
Yeah, you have time.
Yep. So I will be talking just briefly about what are actually the more pressing problems that we see in stroke care. As actually, we know that stroke is a very devastating and debilitating conditions for our patients. So basically, what are the issues and challenges that you can see in old patients is that impaired physical mobility. They always have chronic pains, issue with balance, self-care deficits, impaired swallowing, urinary incontinence, breath sores, cognitive issues that I think have been covered earlier, and then mood disorders, visual impairments, hemispatial neglect, etc. So basically, when you talk about stroke care, it's not about just equivalent, rehab is not equivalent to physio. I think this is a misconception that most Malaysians have had. So if you a doctor referred to for patients for stroke care, is not equivalent to just a physio. So we can see that it's a multidisciplinary approach of encompassing occupational therapy, speech therapy, nursing, clinical psychologists, sports therapists, podiatrists, physicians, and any other healthcare professionals that is not being covered here. So what the goal of rehab that we're actually looking at is to prevent complications, correct deformities, and also for fall preventions. We actually want to enable and motivate our patients to be participating in functional activities with their limitations. So how actually we overcome the limitation is through prescribing adaptive strategies and use of assistive devices, which I will show you later. So transitional care of stroke patients is always the challenge, because carers are always being poorly understood about how, and also ill-prepared on how their responsibility and their role and how they are going to face at home. So indirectly it causes a lot of strains, and due to ineffective coping, and that is causing more problems and leading to depressions and deterioration of physical health for the carers. So what are the common reasons for non-compliance to outpatient rehab? As we've seen, is that you can see most of the time is accessibility. So patients do not continue the care for stroke because of accessibility, like for example at home, transportation access, elderly living alone, unsupportive family members, and those who thinks that they don't want to be inconvenienced of their family members. And lastly will be the financial constraint, which is also part of the reason, because it's actually quite expensive for home rehab charges, as we can see now. And these are the predictors of poor rehab. So what will be the poor rehab outcome? Age definitely was one of the dependent variable, and ADL dependency is actually one of the main issues and predictors of how the patient is going to cope after a stroke. Other issues would be like urinary bladder incontinence, cognitive impairments, and pre-stroke dementia. So basically, I'm going to just share with you about some of the strategies that we're going to introduce, how we actually can enhance. So you can see actually for after a stroke, there's a lot of one-handed techniques that you can use using different devices, helping them to teach and adopt coping strategies to help them retrain the basic IDLs. So these are some of the examples. And actually that we should actually encourage them to keep on participating on shopping and medical routines. This has been proven that actually help to improve the outcome of the patients for stroke. And for patients with bowel and bladder incontinence, which is affecting about 30% of the stroke patients, so scheduled regular voiding is very important, and help them to actually to use intermittent catheterization if needed. And then actually the best is to actually have a prompted and scheduled voiding 20 minutes to 40 minutes after meal. And obviously this is also a constant problem with stroke patients is infections, and elderly with stroke have higher risk of infections, and that can even double with those who have comorbidities and those with prolonged hospital stays, immobilization, etc. And obviously when it comes to stroke, hemiparesis is not just the only problem. They also face with muscle atrophy and also limb spasticity. So when it comes to certain patients, especially with their the flexor synergies patterns for stroke, so basically we can actually provide splinting, correcting positions, and apply certain techniques. And this is one of the devices we can use. This is called splint. So different splint for different problems to actually correct the deformities. And obvious pain is another big issue. With neglected complication of stroke, and actually as you grow it become a bigger problems. So you use of suitable modality should be consulted by the professionals. And I will say that to improve the mobility and preventing joint deformities, I will advise as such. I don't have much time, but basically just to explain to you, continue to promote use, especially when it comes to patients, even they are bedridden, they should be turned every 2 hourly during their waking hours only. And then we try to actually position their hands despite the limitations in the spasticity in the hands, we actually can help them and position them using different techniques and also assistive devices. And for home inaccessibility, basically this is also a big issue, especially with stroke patients. Falls is always a problem. How actually we ensure the home safety accessibility, we should we can actually consult professional occupational therapists, including community mobility and post-cognitive impairment issues, sensory motor deficits, improving communications, and always try to detect early signs of post-stroke depressions. And as conclusion, to ensure continuity of care, I will urge that most patient family members, caregivers should continue carry out daily activities, minimally at least 3 times per day at home, and then activities should be periodically evaluated and reinforced by the therapist. And basically that's the end of my talk. Thank you.
Hello. Thank you, Matthew, for the very brief and sweet and informative presentation. Okay, that's the end of today's, this symposium. So we'll proceed with the next session. Thank you.